So we'll take questions at the end of the whole panel. So, Dr. Pham,
Thanks,
are you ready to go next? Yeah.
Yeah.
Thanks.
Let me, so those are hard acts to follow, but let me try to take a step back and come at this from a slightly different perspective, a slightly different question, which was the one I asked myself about whether we've actually saved primary care since the 1996 report. I think we know the short answer, or maybe I shouldn't assume that we would all agree on what the short answer is, but just taking you through how I approach thinking about it. And, I think as has been implied by both the first two speakers, it is important to acknowledge that something has happened in our march to the goalposts in the 1996 report. The landscape has changed dramatically. This is not necessarily about the goalposts having moved, but rather all kinds of headwinds and crosswinds and ground shifting under our feet. And as you go about your work, I really hope that you make some explicit acknowledgments, concrete, quantitative acknowledgments about the shifting landscape to assess whether those goalposts need to be made even more proximal, I guess, or more tactical in order to make progress. A lot of this will seem familiar, but I think that it's worth calling out that in the time since the report, we've seen a marked shift in market consolidation, both vertically and horizontally. And that means that there are many health systems now having absorbed a great number of independent medical groups. And in many cases, some of the higher performing medical groups. This has all kinds of ripple effects in the broader healthcare delivery system and in the way that patients and consumers experience healthcare, as well as the ability of policymakers to influence those market dynamics. We've seen increasing growth of venture capital investments flowing into primary care, as well as into other healthcare ventures. What the good and the bad of this on net will be remains to be seen, but it's undeniable that it has affected the dynamics between different healthcare actors, and it has affected how healthcare gets presented to consumers in many cases and to patients. There are now many more multi-state entities in the healthcare ecosystem that, again, changes the underlying relationships between payers and providers, between providers and patients, between policymakers and everybody else. Some of these multi-state entities are incumbents who are expanding their reach. Some of them are disruptors. Whether or not the disruptors will actually get a strong enough foothold to affect the underlying dynamics remains to be seen. I think that open question mark is an opportunity for policymakers to step in and send a clear signal one way or the other about whether incumbents or disruptors will be favored, depending on whether the assessment is that a particular type of disruptor is going to be healthy for the system. But nevertheless, all of this is roiling out there. We're also experiencing really significant generational and cultural changes among clinicians themselves, what they expect from their careers, what they expect from their work-life balance, what they expect in terms of their relationships with patients, their relationship with technology, and the arc of their career, how long they will be in direct clinical care. These changes, I'll come back to later, I think are far outpacing whatever evolution is happening in our training pipeline. And I think that that's a problem. We're seeing tremendous shifts in consumer, purchaser, patient expectations. And I want to emphasize here that these are not, but while there are certainly broad trends, I think what's really important to recognize here is just how segmented and fragmented these expectations and sort of cultural memes about healthcare have become. And this is going to be a challenge, I think, for the committee, because it implies that a one-size-fits-all approach is clearly not going to work. And designing a system that is nimble enough to offer the kinds of multimodality, multi-level options in care delivery and primary care will be a real challenge. That's going to be a challenge to articulate that vision in a way that is cohesive and inspiring, but still realistic. And then last but not least, I hope that we were all knocked back on our heels when the JAMA report came out last September, documenting a plateauing of life expectancy and increasing mortality for Americans in midlife. I think it really begs the question, what are we doing here? And how close to goal are we really if primary care is intended to be the first line of defense in health, or health care at the very least, and ideally health as well. And this is the outcome that we're looking at in this day and age. And then last but not least, I think it's important to acknowledge that COVID-19 is causing some severe and acute clinical and financial stresses on primary care. The long-term effects, we will have to all wait and see. I think others have spoken, or others will speak a lot more about the role and prominence of telehealth and other digital tools, and how the expectations for those services will have shifted, perhaps permanently, throughout this crisis. But what I'm really focused about, in part because of my day job responsibilities, but also because I always have this eye toward the long-term primary care infrastructure, is I'm very concerned about the actual viability of independent practice and the actual risk of insolvency for meaningful segments of the primary care delivery system. And then questions about primary care's role in public health, as was mentioned earlier, I think we as a country are going to have to grapple with for real. I won't linger here because I think we're all very painfully familiar with how suboptimal current information technology is in many ways in terms of actually supporting primary care as it's meant to be practiced. It offers many opportunities, but also lots and lots of challenges that we have not yet managed to address. Landscape has changed because we spent the last 10 years experimenting with value-based care. And, what we tried to do in this movement was to ignite delivery system transformation, to make it more team-based, to offer incentives for people to focus on population health, to be proactive, and to at least attempt to engage the entire medical neighborhood rather than leaving it purely on the shoulders of primary care alone. And we've tried to marry that with payment reform, even though the tools that we have to work with there are essentially just kind of reordered, reconfigured ingredients we're very familiar with. As Jamie Robinson famously said, the 3 worst ways to pay physicians are capitation, salary, and fee for service. And so that's what we have. It's a question of how we deploy them and how we price them. So I think we would all acknowledge that we're not quite there yet. In terms of having payment that is truly prospective, truly multi-payer, consistent, rationally risk-adjusted, married with quality guardrails that are meaningful as opposed to numerous, and that actually take into account patients' experiences and perspectives. Measuring primary care spending, that lots of folks will touch on that with you, and so I won't delve in there except to say, obviously, there's a lot of work to be done there, and I think we need to be very crisp and err on the side of simplicity in order to build momentum with an eye toward refining that definition further down the road, because holding up measurement and transparency into where any such metric is will do more harm than having a metric that is somewhat less than optimal. And then lastly, and this is a real pain point for me because of my personal quest over the past 20 years, is that we've made a little bit of progress in repricing primary care, but not enough to have it really change the experience in the marketplace. Change the experience of primary care providers feeling value, change the experience of new medical graduates choosing primary care, And frankly, when we talk about increasing primary care spend, there are really only three components, right, that will help you move that metric. Either you increase the prices, or you increase the utilization of units of primary care, or you increase the categories of things that you call primary care spending. So if we can't move the prices much more dramatically than we have, I think we're going to hit a wall on that overarching metric. We've seen a growing commitment to addressing social drivers. Again, I won't linger here just because other folks are going to talk about this or have talked about it and will be much more eloquent. But I do think that it presents a tremendous opportunity for primary care. And it's not clear yet that the field has really stepped up. So how have we adapted? Again, this is about, I think, internal reflection about what is within our control, but also asking ourselves the hard questions about what arguments, what battles, what collaborations, what engagements have we actually avoided or skirted or diluted in the years since the report that we really need to double down on now. We need to, do better than this polar bear has. That coat needs to start turning brown. So when I look back at the report, my high-level assessment is that in terms of the definition of primary care, it still does hold in a very fundamental way, but it's being applied in the real world in such an uneven manner that it's really robbed of its meaning. Primary care itself as a field lacks a single cohesive voice. And that's very hard for me to say as someone who has collaborated with many of the leaders in the field. But I also experience the fractiousness when it comes to political decision-making and prioritization. And that hurts primary care because those competing voices trying to get policy attention and resources in the marketplace are much more cohesive. There's very little public understanding of or demand for what we might conceive of as advanced primary care. And yet, as I think, we've already heard, many patients know it when they feel it. Once you have a primary care provider, your loyalty to that provider is extreme. And that carries through all the life stages as long as insurance coverage applies and you have that option. And I think that that's a tremendous foundation to build on. But we have some challenges because more and more young people do not have a primary care provider that they identify with. And until we get that hook into them, they won't experience or act on that loyalty. So how would I grade policymaking and the response of the marketplace in terms of getting to goal or getting to the goals as outlined in the 96 report? I think in terms of insurance coverage and availability of primary care, this is out of 5 stars. It's very gross, and for sure you will take issue with it. And perhaps when I filled this out, I was having a particularly dark day. But I would say we've made some progress, particularly with the Affordable Care Act and with Medicaid expansion. But we still have some ways to go. Still double-digit millions of Americans without health insurance. Payment methods that support primary care functions with value-based care and kind of a meaningful plurality of American providers now in alternative payment models. I would say we've made meaningful progress, but again, not necessarily to the depth and for sure not to the breadth where it may permanently shift how well primary care providers can execute on those core functions. Higher prices, we've done less well there. Interdisciplinary teams, at least this has become an expectation, even if the execution is uneven and the resources are not always available. At least the expectation is there, and it's beginning to creep into training venues, which gives us hope about what future generations of providers will approach the work with. Embedding primary care and care for underserved populations, I do think we've made meaningful progress here, but again, only to the extent that we can marry that with insurance coverage and primary care supply. I don't think we've made much progress on explicit collaboration with public health, as I think we're all experiencing currently. I think that there has been some early movement on integration with behavioral health, collaborative care payments, increasing accessibility to behavioral health specialists through digital and other asynchronous or remote means helps with that. Models like ECHO help with that, but we are certainly nowhere near the point where it is a given that primary care and behavioral health care can be integrated in any given point of care. No movement on integration with long-term care. And in terms of uniform and meaningful performance metrics, there are pockets of collaboration and alignment. Having CMS taking a leadership role certainly helps with that, but there's still a tremendous degree of fragmentation and frustration as a result in the field. We've made some progress on the workforce, but I cannot say with confidence that the institutions training our future clinicians have really anticipated what care delivery of the future looks like and are planning for that. Geographic maldistribution is only heightening, and we have the macroeconomic trends and the macro mortality trends to illustrate some of that. Scope of practice constraints are still a significant political barrier. And retraining, MOC, has certainly become more prevalent and expected, but remains contentious. So in conclusion, I think much of that report remains relevant, but the changes in our macro environment require that this committee really take a hard look at updating the goals and strategies for primary care. And primary care itself as a field is coming to a reckoning. There's been a lot of conversation and a lot of great work, but at the end of the day, some of the hardest conversations and some of the hardest work we have intentionally set aside for another day. And I don't know that we're going to get that other day. So my question for the committee is, will the next report inspire true transformation? Thanks.
Dr. Pham, thank you so much.